Welcome back. And to kick off our second session, there's no better person than Diane. As you know, UPMC has actually been very, very far in front of the curve, and especially with the idea of merging insurance experience with the providers. And from my perspective, as you'll hear later, is always very patient and family focused. The health plan, I think, has been a leader in understanding what the patient/consumers' needs are and developing programs from wellness to sickness to take care of them. So I don't know if Diane really doesn't need an introduction to this group, but I'm very happy first for the sponsorship and second, certainly to have you share your thoughts. Diane?
Thanks, Tony. So hello. Ooh, it's a little sensitive. Hi. So great to be here and great to help Dr. DeGioia bring this group together and also bring the kind of expertise to town that I think helps us think through what are the things that we're really trying to do when we talk about improving outcomes in healthcare, both the clinical quality and cost outcomes. So how do we think about that? So what I wanted to do is I'm going to turn the conversation, slightly right angle it a little. And just by way of introduction, because I think that the overview that we're talking about here today is in the context of a world that's saying, how are we moving from a volume-based system to a value-based system? And if we're really thinking about what's going to matter in healthcare, the conversation of price becomes critical. So, Jamie's conversation earlier on how do you think about putting together competitive methodologies that allow you to price and get a price that is sustainable. But I'd also ask you to think about the fact that when you're talking about healthcare delivery overall, all of us want a robust and sustainable healthcare delivery system. Nobody is trying to say we want to go backward in terms of the kinds of services and capabilities we have in this country. What we're just saying, I think, is we want to make sure that we get optimal value for that. So when we talk about the fact that, Medicare payments, providers will break even on them, and Medicaid pays you under cost, and, if you have, people without insurance at all, there's very little payment. And so consequently, all this cost shifting we've talked about over the years to the commercial market is a real problem. As we try to figure out how we're not going to overpay in the commercial space, we have to talk about the sustainability of all. And that means we're going to need to take waste out of the system. So that means not only, administrative waste, which I think we really have to talk about how to do that, but we're going to have to figure out what's not necessary. And we're going to have to think about the combination of incentives that matter. So we're talking about incentives for provider systems and insurers, and we're talking about incentives for consumers and for the employer community. Because at the end of the day, the purchaser is not just the employer, right? And it's not just government. At the end of the day, it's the individual, right? It's the consumer who, through whether it's paying taxes or basically seeing wage compression because their benefits are taking up all the extra dollar, we really have to talk about how to fix that. So I thought I would just in case there was anybody who doesn't know who UPMC is in the room, and I thought there could be a couple, we are an integrated delivery system, as you know. And the health insurance part of the UPMC was launched in 1996. So we're going to hit our 20th anniversary soon of having a health insurance division. And what we've seen over time is that this particular approach has had viability for us in order to bring forward to the community what we feel have been competitive offerings, but it also has foreshadowed what's happening in the nation in terms of a lot of the work that's happening today and where a lot of systems are going. We are, for those of you who don't pay attention necessarily, and I don't expect that you're all paying attention to what the UPMC health plan's up to, but we have 7 licensed insurance companies. We have a lot of other companies that sit under this umbrella, and we have grown now to be the 2nd largest in the nation in terms of all insurance premiums that sit under a provider auspices. Kaiser's bigger than we are, but pretty much there's no regional health plan in the nation. We're bigger than a large number of the Blue Cross plans in the country. We offer virtually all products and services, and we have seen exponential growth across the last many years. And I think I hope that's because people have found that it's a value proposition that for not all, but for many, seems to work. So that's my real last commercial, but I did want to just set the context, because if it were not something that so many other entities in the country are starting to emulate, it maybe wouldn't be as valuable a conversation. But what we've seen in the last year is that exponentially the growth of what is called accountable care organizations nationwide has really skyrocketed. We have well over 600 provider-owned, whether they be doctors, groups, hospitals and doctors together across the country that have formed these entities. And a significant percentage of them have Medicare dollars that they're trying to manage. Many of them have commercial dollars they're trying to manage. And they're coming together sometimes with an insurer, sometimes not, often not. But they are working together to collectively look at total cost of care, with the goal being that they want to improve clinical outcomes as well as cost outcomes. So some of them have gone on to form insurance companies. There are well over 100 provider systems in the country that have formed insurance companies, and the number in the pipeline is significantly higher than that. One of the initiatives that UPMC Health Plan took on about 4 years ago is developing a joint venture with the advisory board in Washington, essentially helping other provider systems around the country form the infrastructure to build their own health plan, or to form an infrastructure to go at risk with another payer in their market, or perhaps many payers in their market. So one of the things I think is important to keep our eye on is what is this evolving system that's happening. So networks get a lot of attention, and you probably all read that, last year on the federal exchanges, 70% of all the networks people selected were considered narrow or ultra narrow. Fully 35% were ultra narrow, which meant it had well below 50% of the providers in a given region in that network. We're looking at what is the impact of that, and how are we thinking about value networks being built. And I would caution you to potentially stop using the word narrow network, which I see out there being written a lot, because essentially a conversation that I think we should be having is what's a value network. And that's the conversation I think that we should be taking forward, because then when you talk about a value network, you can begin to talk about, well, what are all those things that Jamie was just talking about, and how do we think about the reference-based pricing inside of that? Or how do we think about the bundled payments being offered? So we at the health plan had launched, Tony was very active in it, bundled payment for hip and knee. We put that together over the last couple of years, have watched the data come out over the last year in terms of how it worked, got every senior orthopedic leader person in UPMC together at that table, and Tony can tell you it was pretty, right? It was like, it was what devices, how much blood product, what kind of blood, how do we think about this to really bring together doctors and hospitals? And then what was the plan's role in saying, well, hey, if I want to get a better arrangement for my member on cost and quality, I'm assuming you're going to have these quality gate you go through, but at the end of the day, we have to save money, and if we don't save money, that's not a value proposition that's good enough. Improving quality is a really important agenda, but that has to be married for us to improve quality while you contain or reduce costs. So that has been an ongoing, really exciting, I think, development. Some of you may have seen the Brill Time Magazine article. This was the author that a couple years ago, Time Magazine devoted their entire magazine to what's wrong with healthcare, and he launched a new book. And you may not agree with all the things he said, but one of the things that we found interesting is that at the end of the day, part of what he talked about was the model of integrating care and coverage. And if you can begin to align the incentives between the payer and the provider, can you begin to have truly some better opportunity for people? So we have been interested in that. Now, the other huge driver that's going on outside of what's going on in the private sector is what Medicare's doing. And I always think, of Medicare as the mother of all payers. And my feeling is that we're seeing huge shifts in provider behavior related to Medicare. And when Medicare begins to marry the other government programs and begins to marry the commercial environment, I think we begin to see some significant changes. By 2018, virtually 90% of all Medicare payments are going to be related to quality, and they expect and will push a minimum of 50% of the payments being in some kind of alternative payment model. So global capitation, at-risk payments, things that actually speak to the provider community around looking at cost and containing costs. Quality is always critical, so a recent study again, says if you're going to talk about value, then you have to talk about what is that outcome you're getting for the dollar you pay. And the United States, as wonderful as it is in so many ways, and as wonderful as certain things about American medicine is in many ways, we also know that we sit kind of at the bottom of the heap in terms of industrialized nations across the board in our quality outcomes. So let's talk a little bit about what's happened. So healthcare premiums, we've seen the last several years, have not escalated at the rate they did historically, so that's a really good thing. Medicare, in its 50 years since it was invented, has never performed better in the Medicare fee-for-service environment in terms of cost containment, so that's a good thing. And when we look at the Pittsburgh market, I don't know how many of you, are aware of it, but if you look at commercial premiums in the Pittsburgh market, we are, of 25 top markets in the nation, we have the lowest commercial premiums here. And if you look at all 60 markets, we're third from the bottom in terms of lowest premiums. So Pittsburgh has been a well-performing market in the commercial space. Now, what does this mean in terms of household income as compared to what's happened with insurance premium? Still not a great story because household incomes have not kept up and inflation continues to be a problem, and so real wage growth has not occurred, and health insurance costs continue to go up higher than we can afford, right? So we still have a problem even though we've seen some flattening. So what's happening? What are purchases doing? What are we thinking about in this room? So what's an individual person asking when they're what's the biggest question I will tell you we get when people are looking at our exchange products and our other networks? Is my doctor in that network, right? The individual is pretty focused on that. What's a company doing? They're looking at various networks. There's choices in Pittsburgh. There's choices around the country. Most major markets have multiple choices in terms of networks you can purchase. And the employer is saying, well, if I got to buy for a group, right, I want to make sure I got an adequate supply in my network of what I need. And so this conversation where a handful of years ago we were talking about everybody needed a big PPO, everybody needed everything, I think culturally we've made the decision that doesn't work and we're not going to stay there. Will there be backlash? Will there be problems associated with it? Of course there will be problems associated with this. But as we move in a direction that says the consumer is going to be willing to trade off certain things for a better price, this is going to be one of the things that we're going to be looking at for, I think, quite some time. So if we're going to talk about trying to get our hands around affordability, and we're going to talk about what it's going to mean over time. Of course, reference-based pricing would be useful. Bundled payments helps us in certain kinds of ways. Lots of different payment models, but at the end of the day, as the consumer gets more and more engaged, will I ever make a relationship between the pizza I eat and the price I pay for something in my healthcare costs down the road? Do I have any capacity over time to see a relationship between what drives the cost of healthcare up? Pricing's definitely one of them. We can talk about, provider consolidation driving, all the different things we can talk about. But there is a relationship to the consumer in terms of what kind of health status they have and what kind of health care they need and how they can get that at the most affordable price. So this is a sign not far from one of our hospitals that I stole from Dr. Parkinson. Basically says habits. It's where you can, after you get your MRI, you can pick up your beer and cigarettes. Chronic disease continues to drive 75% of healthcare costs in this country. And I'm just displaying for you the obesity maps on the top line, showing that the country gets heavier and heavier over time, and showing you the corresponding diabetes maps on the bottom that shows you, I'm not suggesting it's only causal there, but there is a correlation, and I think there's certainly a relationship that most of the physicians will tell you. Now, look at those other charts where, I don't have to tell the actuaries in the room or the people who study health employer benefits. You people look at these kind of numbers all the time, right? So you know that a very small percentage of people are driving a very big percentage of the cost. And you know that we've all been working lots and lots of ways in lots of methods trying to figure out how do you help people from moving up the curve from getting so expensive. And some people you're not going to prevent from getting very expensive. You might be able to control what the pricing is at the top of that line when they get that MRI or they get that cancer surgery or they get the kind of services they need. But there are certain people who are going to be expensive no matter what. How do we get better value for the purchasing, right? But how do we as a culture and as an industry, whether it's on the provider side or the payer side or the employer side, how do we actually begin to build a methodology that people care about this and see the relationship? Tony has told me repeatedly, if we could just do something early, I won't be doing so many hips and knees, right? I mean, what the data that he wants to look at with us is how do I go way upstream to those people the first time somebody complains of knee pain? So I can intervene 10 years before that surgery is going to be needed and maybe prevent it completely. So that's the kind of work that has to be done in that space. So this says, have you heard 250 is the new 180? Well, on some level, it's a little bit of a joke, but it's not really. People have to really look at these issues and wait, although for some people it's not